my absolute pleasure to introduce Dr. Mason Jager, who is visiting here, working actually for a week with Dr. Carrie Schaefer, learning about organoids and the incredible work she's doing with those tools so that Mason can use them in his research. So we're very fortunate to have him here and to be connected with him. He is a veterinarian who graduated from Cornell Vet College. Apparently this list is really easy, actually. He then did his residency in anatomic pathology, again at Cornell, and we weren't holding him against him, but he also did his PhD in equine parvovirus and virology at Cornell. And so he has finished that work recently, and he currently works at Cornell doing 75% research and then 25% on the floor as an anatomic pathologist. So we're very fortunate to have him, and he's here to share with us today some of his work on equine viral hepatitis. Thank you.
Great, thank you. I'm very happy to be here. Thank you all for joining us this afternoon. So this afternoon, I'm going to be talking more about some of the clinical aspects of the viral hepatitis, not as much some of the actual benchtop research that I do, but I'm happy to answer any questions at the end if anybody has any. And please feel free to interrupt and raise your hand if you have any questions as we go along. Excellent. So I'm going to start off just a little bit of history to kind of give us some context of where these viruses are in history. And then I'm going to go through some of the different players that we talk about in the literature just to help maybe clarify some questions on who is doing what. And then at the end, I'll just do a couple slides on some current projects and how that ties into what I'm doing here with the Schaefer Lab. I wanted to start off with just some acknowledgements because this is not work that I've done alone. I've worked with a great team over the years, specifically my advisor for my PhD, Dr. Glenda Vanderwall, and Dr. Joy Tomlinson. Joy is boarded in internal medicine and does significant research on the clinical aspects of these viruses. So most of this work on equine hepatitis, and then some of the tropism studies and infection studies are driven by her. And so she's done tremendous work in that area. Also, my collaborator, Dr. April Choi at UC Davis, was critical for one of the studies that I'll talk about. And then, I stand on the shoulders of giants. So specifically, Dr. Tom Divers and Dr. Bud Tennant, both of whom had put in significant amounts of effort over the years to studying these viruses. So that I owe them my thanks. So just a little bit of history. So the story with these viruses actually starts over 100 years ago with this gentleman here, Sir Arnold Tyler, which may be familiar to some of you. I noticed that he actually has a plaque at the Gluck Institute in the Hall of Fame for Equine Researchers. So I thought that was very fitting. He looks a little bit younger, a little bit more handsome on your plaque than in my picture. But one of the many things that he accomplished during his time in South Africa was developing a vaccine for African horse sickness, which was ravaging the horse populations at the time. And so he developed a technique where you pooled serum from horses that had been infected and recovered from the infection and combined that with live virus. And then he inoculated naive horses, military horses with that. And then what he noticed was that over a period of 6 months, they had 27 cases of hepatitis, which was unusual in that population. And of those horses, 22 had died, reaching about a 2% mortality, all with very similar clinical pictures. He'd also noticed that in horses that were co-housed with those horses that were immunized, a portion of them also developed hepatitis and died. And this led to the suspicion that there was some sort of component that was transmissible through the serum or the live virus, but also contagious because it was being transmitted from horses that had been inoculated to horses that had not. And he had suspected a virus at the time, but could not identify one. There were some implications of perhaps a new plant toxin. And we still see this disease today, and it's known as Tyler's disease, named after him. And it's characterized by severe acute hepatic necrosis. And clinically, we'll see this as an acute onset of hepatic encephalopathy most often. So you have signs of blindness, head pressing, staggering. Sometimes the horses are just found dead. It can be very acute. This is something that can happen over hours without any premonitory signs. Typically, we see this 4 to 10 weeks or so after administration of a biologic, usually tetanus antitoxin or even stem cell therapy. But we do see cases that don't occur with biologics, and these typically happen in the summer or fall. So as I mentioned, this was a mystery for 100 years. There was no known cause of this condition. We knew that we could create it with the equine biologics, but no agent was found. Thanks to the next generation sequencing, though, we did have a few contenders come up in the past 10 years, and those are the ones that I'm just going to kind of work through a little bit. The first one up is equine parvoviruses, and this is a great one because it's a pretty short story. So we had two parvoviruses that were identified, both identified in 2013. One, unfortunately, was named Tyler's disease associated virus, and the other one, equine parvovirus 1. And I say unfortunately because it actually has nothing to do with Tyler's disease. That was a mistake. And so both of these viruses have since been demonstrated to cause persistent infection of the bone marrow and not the liver, and they are not associated with hepatitis. So for clinicians, I recommend you can just go ahead and get rid of the parvovirus, as it's one less you have to worry about. The other two, though, are clinically significant. And so the next one up is equine hepatitis. So this is a flavivirus. It's actually very closely related to human hepatitis C. It's actually the closest relative of any known hepativirus to date. It was originally sequenced from a dog, but was subsequently found to actually have the horse as a host. And this virus is prevalent worldwide. And so, over a number of series of studies, we've seen up to 40% of horse populations be PCR positive for this virus. Even greater portions of that are seropositive. So they've been exposed to the virus and then either recovered, and had developed those antibodies. And interestingly, donkeys are susceptible too. So it seems like it's pretty broadly applicable to our equids, not just horses. And much like we saw with Tyler's disease, we know that we can transmit this virus iatrogenically through blood or biologic products. Some studies have also demonstrated that the virus can be transmitted vertically from the dam to the young. What's unclear is whether or not there's an insect vector playing a role. This has been postulated for hepatitis C virus, but so far has not been demonstrated for equine hepativirus. There's also questions of whether it can be transmitted through nasal or oral routes. And again, this is something that is currently being investigated, but has not been clearly answered. And so clinically, what we can see, it appears to be that there's different manifestations of disease. So you can have the most common manifestation is an acute resolving infection. So the horse gets infected, clears the virus, may be sick for a couple of days, and then it is fine thereafter. And that's the most common on the left here. We also see evidence of persistent infection. And when you have persistent infection, it can go one of three ways. Either resolve, like that first case, the horse can develop hepatitis, and in some instances, actually, it can be fatal. You can have fatal disease, and we'll talk about that a little bit more. The good news for our horse owners and equine practitioners is that most horses clear the virus within about 6 months. So 80% clearance by that period of time. But we do have occasional horses that still have a peak of viremia up to 2 years out from that initial infection. These are experimental infection studies. And what can be challenging from the clinical perspective is how to diagnose this, because the period of viremia is longer and higher before you even see elevations in those liver enzymes. And so in this graph, this little dotted line is the viremia, and these different colored lines represent the different serum biochemistry values. And so what you can see is that those values don't increase until pretty much the tail end of that viremia. So if your horse was sick around 12 weeks, and you did a blood sample, you might see elevations in blood values, but your PCR for equine hepativirus might be negative. And so this can be kind of a tricky situation. Histologically, if there's any, for our pathologists in the room, it manifests as a classic viral hepatitis. And so we see lobular infiltrates, lymphocytes, macrophages, sometimes neutrophils. And then associated with those infiltrates, we see necrotic hepatocytes, which are these kind of shrunken, hypereosinophilic and rounded cells here. Unfortunately, we don't have a great modality for visualizing the virus in the tissue. Some papers have used in situ hybridization. I'll talk a little bit about that later. We have had trouble getting that technique working ourselves. We are currently validating one at our diagnostic lab, but it is an RNA virus, and RNA, as we know, is fairly fragile and sensitive, especially in formalin-fixed tissue. So that is presenting a bit of a challenge in our studies. So I mentioned that this persistent infection, that 20% of horses is out there for equine hepativirus. And when we compare that to human hepatitis C virus, it's a little bit of the reverse. So about 80% of humans that have HCV infection will develop persistent infection. And of those, 10 to 20% will develop chronic hepatitis with cirrhosis and sometimes hepatocellular carcinoma. Equine hepativirus is the flipped version. So only about 20% seem to develop persistent infection. That could be higher in foals depending on their immune status. And so we had a question of, well, what about chronic disease? Do we see it like we see in humans? And the answer is yes. So there's only a couple of case reports out right now that describe chronic cases of equine hepativirus infection where that viremia is persistently high for many, many months. And we can see elevations in liver values. And then on histology, we can actually see evidence of fibrosis, which is a classic marker of chronic disease. And this slide is old. We've now actually, I think, got up to 30 cases that Dr. Tomlinson has been recruiting over time of these chronically infected horses. Some interesting data. So most of them are teenagers in terms of age. We do see in this small data set a predisposition towards geldings, which is also interesting because in humans, males are predisposed to developing cirrhosis and hepatocellular carcinoma. So there does seem to be an age skewing. Small n, so we're not trying to overinterpret it. Pretty broad mix of breeds, but many of them show up with the same clinical signs. So weight loss, inappetite, dullness, and sometimes photosensitization. It's a little bit blurry here, but you might see a little crust on this nose, and that's in the area of the white skin. So it's more exposed to UV injury. And the typical blood profile that we've seen in some of these chronic infections is elevation in our biliary factor. So GGT, bile acids. We do also see some leakage enzymes, so AST. And an interesting finding is an increase in the hematocrit, so polycythemia. Many of the I won't say almost all, many of these horses that are chronically infected have a hematocrit of about 55 or greater. And so if I have a horse that's presenting to me on my paperwork that has hepatitis, based on blood work and an elevated PCV, I'm almost always thinking equine hepativirus. And so far that's been pretty accurate. So it's a kind of a low-tech way to kind of guide your diagnostics. Obviously, we have more work to do to demonstrate that. But on ultrasound, if you do have a chronic case that is progressing with fibrosis, you can see these changes on ultrasound. And so here on the left, we have the ultrasound, and on the right, we have the gross pathology, and you can appreciate these nodular areas. I won't quite say regeneration because I'm not 100% sure that they are regenerative in the classic sense, but they're areas of normal hepatic parenchyma. And this is what we see histologically. So there's usually either one or the other in one case. And so what we're looking at in these images is fibrosis. So red are the hepatocytes and blue is collagen deposition. And so you can see significant dissection of this collagen between the hepatocytes. So that's dissecting fibrosis. This significantly impairs the function of those hepatocytes and is what contributes clinically to the decline of the animal. We can also see probably the more histologic correlate to that gross image where you see these nodules of hepatocytes separated by these dense bands of collagen. And again, has significant implications for the function of the liver. So one of the interesting things, we also have lymphofollicular aggregates. So these are areas in portal tracts that mimic like a lymphoid follicle. So we have a mixture of T and B cells, and this is a feature that's almost not quite pathognomonic, but very specific for human hepatitis C in humans. And this is a feature that we are seeing in some of our cases of equine hepativirus. And then lastly, as I mentioned, kind of a classic viral hepatitis, you have lymphocyte infiltrates and necrosis that continue on into the chronic phase. So we have these kind of two different presentations that we understand right now. So, again, if you're a clinician and you have one of these acute resolving cases, you may not pick up that viremia depending on where you're testing and how that animal is presenting clinically. That being said, if it's acute resolving, your horse is probably going to recover and you won't have to worry about that again unless there's recrudescence later on. The problem horses are the ones that have that persistent viremia where despite, where you do serial PCR tests and those levels are elevated each time. And what can be concerning is if you're monitoring those serum biochemistry values over time, that those are also staying elevated. In those cases, we recommend doing biopsies over a period of time just to see, where you are in the disease. If you're in the earlier stages of chronic disease or closer towards those areas of the development of that fibrosis, it's important for prognostic factors for the owners. Yes?
So tell me for my understanding is correct. So is that for passive virus that the viral loads go down They will use them with that.
Yes.
So, okay, that makes sure, this is something new.
Yeah, and so you'll see something very similar with equine parvovirus. And that's what's interesting about both of these viruses. They're actually similar to human hepatitis B and hepatitis C virus. So the virus itself, and we don't know this for sure yet for these, but I suspect that they are infecting the cells, but not in and of themselves damaging those cells. They're quiescent, right? They're replicating, but they have mechanisms to prevent cell death. But then the immune system gets involved, which takes time to develop. And once you have seroconversion, then you have destruction of those cells, and then you have the leakage of the enzymes. Yeah, and so you'll see that'll be a kind of a common theme. Yeah. Thank you for the question. So just to summarize, so equine hepativirus is out there. In the US, we have a prevalence up to 23% in some studies. Subclinical acute cases are the most common manifestations, so not too much to get worried about. But we do see cases of subclinical to fatal chronic hepatitis in some instances. Best diagnosis is through serial PCR and serum biochemistry, plus or minus biopsy, depending on what those results are showing. You can have a high viremia chronic carrier state before or during hepatitis, as we talked about, depending on whether it's acute resolving or chronic and persistent. And currently there is no treatment or prevention, although this is something that Dr. Tomlinson is working on. Okay, now to my favorite virus, only slightly biased here, equine parvovirus. So this virus was first identified in 2018. So this is the latecomer to the viral hepatitis game for horses. And like the others, it was identified using next generation sequencing of liver tissue from a horse that had Tyler's disease. And this image in the upper right here is kind of a classic image of what we call a dish rag liver. So the idea is that it's had so much necrosis that it's now just kind of floppy. It doesn't have anything to hold it together. Now, after being burned 3 times before in terms of identifying a virus and having it not be associated with Tyler's disease, the group was a little bit more cautious this time. And so they did a couple of studies looking to see if, prospective studies to see if cases of Tyler's disease were positive for the virus. And in one group where they had association with biologic administration, all 18 of the horses that had Tyler's disease were positive for equine parvovirus and negative for the other viruses. Likewise, in cases that had no association with a biologic, all 9 of those horses were positive. So it wasn't a perfect score, but it was pretty convincing. And this has been shown, in multiple studies since then, this association between having the virus and cases of Tyler's disease. But being a cautious anatomic pathologist interested in viral pathogenesis, I know, and obviously from those other lessons, that just because you have a virus does not mean that it is causing a disease. And being the pathologist, I need to see it to believe it. And so this is a tool that I have used many times for other new and emerging viruses, and I found it very helpful. So I figured I'd just mention it because I use it pretty heavily. And in situ hybridization, it's an old technique, but there are companies now that make this a much easier thing to use. And it's a tool that allows you to basically see the viral DNA or RNA in a tissue. And the probes are designed to be to bind to specific nucleic acid sequences. And so you end up with something that's very specific and highly sensitive. And it can be really helpful when dealing with new viruses because once you have a sequence, you can submit it to a company and have probes in your hands within 2 weeks, which is much, much faster than waiting for antibody development, which can take months or sometimes years to validate. These are what the little probes look like. They're Z-shaped. And the way they work is that they actually bind, they have to pair up. That's what adds some of our specificity on a sequence of nucleic acid. And then you can add these amplifiers that help kind of amplify that signal. And what's great about this is one single puncta that you see visually in the microscope counts as 1 copy of nucleic acid. And they've done some studies to kind of validate that. So with this technique, I was impatient. I wanted to see, okay, is this in cases of Tyler's disease? And it was very convenient because there had just recently been an outbreak of Tyler's in Slovenia, and we had some colleagues there. And so they were able to send their tissues over, and we were able to do in situ hybridization. And in all 4 cases, they were positive for equine parvovirus, negative for the other viruses, and we were able to demonstrate hybridization in those cases. Even yet, these were a little bit autolyzed, and so I believed them, but I wanted something more concrete. And you'll see later we've got some more impressive images as well. But again, being burned, we wanted to try experimental infections. That's the best way to try and understand whether a pathogen is causing diseases. And so we took 10 horses and inoculated them with serum that was positive for equine parvovirus, but negative for the other viruses, and then monitored them over time. And we saw a recapitulation of liver disease. And so we did see, as I mentioned, that classic viral hepatitis. So we have lymphocytes and dead cells. Over here, we can see that those lymphocytic infiltrates are CD3 positive. So those are T cells. Again, pretty classic for viral hepatitis. Sadly, we did not cause, I mean, I guess it's good for the horses, but sad for the study that we did not cause Tyler's disease in any of these horses, which was a little disappointing, right? That's what we're trying to explain this condition. But we did make other headway. So we did demonstrate that this is a hepatotropic virus. So using qPCR of various tissues at the end of the study, we were able to demonstrate that liver and serum making sense, that's where the virus would be. But liver was definitely significant for the viral load. Again, going back to my favorite, the in situ hybridization, we were also able to show that this is a hepatocytotropic virus. So infects hepatocytes specifically, which is kind of important when we're thinking about the pathogenesis. You want to know what cells it's infecting. That lets you know about the biology of the virus. And in our studies, we have not seen any evidence of it infecting biliary cells or their inflammatory cells. It's almost always hepatocytes, which comes into some of our studies a little bit later and creates some of those challenges for studying this virus. And so when we look at a kind of classic representation, so this is almost a summary image of some of those 10 horses and what we would expect to see. So this kind of gray dotted line and the gray area underneath it, this is viremia. And so similar to that equine hepativirus, we see this rise in viremia before we see any elevation in those serum values. And then just as it's starting to drop off, that's when we're starting to see this elevation in serum biochemistry. It also happens to coincide with the antibody levels. So this darker black line with this dot, that's seroconversion. So those are antibody levels. And as those are increasing, that's when we start to see the viremia decrease and the liver values increase. Question?
With regard to those antibody levels in terms of clinical detection, I mean, we would send in blood for PCR, but can we now send in for influenza?
Not yet, not commercially, not for diagnostic purposes. So for this, we use a luciferase immunoprecipitation assay. So we just take viral proteins, bind them to mix them with the serum to bind to the antibodies, and then we're able to do kind of a luminescence test to kind of quantify those. Unfortunately, it's not commercially available yet, or even on a diagnostic scale, but that would be something nice for when you have a positive case with PCR, for sure. Or the negative cases, yes, yeah. So again, the thought here is that as those antibodies are increasing, now they're interacting with those infected cells and causing direct cell immunopathology. So this one's a little bit simpler because we don't seem to have that acute resolving versus persistent infection with equine parvovirus. As far as we are aware, it's a one and done situation. I have not seen yet a case of chronic parvovirus with significant fibrosis, and we'll talk a little bit about that in a minute. So if you're looking for your diagnosis, certainly your serum biochemistry values will be the tip off. Fortunately, if you're getting them somewhere near the peak of viremia, you're still likely to get, if you're doing this during peak elevations of those values, you're still likely to detect the virus in the tissue. But it's that serial PCR that's really informative, because if you go back 3 or 4 weeks later and the virus is no longer present and your values are down, you're probably good. The horse is probably fine, and that must have been, or that's the likely cause of that disease. Of course, histopathology, biased, is always great. I appreciate your biopsies. Or here to the UK VDL. And I've also found in situ hybridization to be very useful for these cases, because just because you're able to detect the virus and see those values, as you'll see in a later study, doesn't always mean that that may be the main driver of what's causing the disease. So far, this has mostly been experimental infections other than that study in Tyler's disease. And I wanted to know, what about naturally occurring virus? Because we know that it's prevalent around the world. So similar to hepatitis, in some countries, including the US, up to 37% of serum samples from healthy horses were positive for the virus. And just like equine hepatitis, it appears that donkeys are susceptible. At least they have seroconversion and they do have viremia. So at Cornell, we have this, this fantastic program. You may have something similar here, where we have a cooperative agreement with the New York State Gaming Commission, where we do a postmortem examination on every single racehorse that dies on the racetrack, whether that's a breakdown, colic, anything, found dead. And so we had this great bank of liver tissues from over 360 horses from 2013 to 2019. And thankfully, our residents collect every tissue every time. And so we had that archive at our disposal. Most of these cases were euthanized for musculoskeletal injuries, which is actually very helpful for us because we wanted to know what is it like in a healthy population? What is the prevalence like? Is this virus just subclinical, or is it hiding in tissues? What's going on? So this was a nice opportunity for us. And so we did a combination of things. We did PCR of DNA extracted from formalin-fixed paraffin-embedded tissue and in situ hybridization of PCR positive cases. And so surprisingly, we found 42 of 191 samples were PCR positive, about 22%, which matches our seroprevalence studies in the US. So that was good. We performed in situ hybridization on those samples. And as I mentioned, we also did histology to see how many of those cases had evidence of hepatitis. And we saw a spectrum of hybridization, everything from just a single cell that was positive in a case to having a couple of positive cells. You have to trust me that there are some positive cells down there. And then we did have a few cases that also had more significant hybridization. And what we noticed was that in these positive cases, there was evidence of that lymphocytic hepatitis. And in some cases, we could see necrotic hepatocytes as seen here in this arrow. And one of my favorite things to see when I'm looking at ISH is a dying cell, like this one highlighted here, that also has hybridization. It's always nice to see that kind of reaction one-to-one. And again, this is an inflammatory infiltrate. We've got some lymphocytes here right adjacent to that dead cell. Yes?
Because I see this. And I see the little bit of every single one of them. And it's most negative.
I totally agree. And so yes, so we did. So our negative controls over here are horses that were negative and had reasonable histology. So the problem with some of these race horses is that it takes like sometimes 16, 24 hours before they actually get to our cooler. And so autolysis was a major factor in interpreting some of these samples. So we went back and found all the negative cases that had reasonable histology and looked at them and compared as well. Because you're right, I see the same exact thing. I mean, horses' liver is the filter of the gut, right? And so they often have something going on. And so, yes, I agree. Still, we did see a significant increase in the positive versus the negative horses, but that's a great question. So while we were doing this study, another study had come out from Austria. And in this study, they were asking kind of a similar question to a study that we had begun, and that's coming up next. And they wanted to know if equine parvovirus is associated with other liver diseases in horses. And so they took a study with 87 horses and 5 donkeys, and they performed real-time PCR for the virus. And they looked at a variety of conditions, including cirrhosis, circulatory disease, toxic, metabolic, inflammatory, and neoplastic processes. And of all those cases, they only had 2 cases that were positive for the virus on PCR. Interestingly, both of those were metastatic neoplasia that probably had nothing to do with the demise of that horse. So their takeaway from this study population was that there was no evidence for equine parvovirus being involved in hepatopathies other than Tyler's disease. But through our diagnostic caseload, I knew that wasn't quite the case in our population. So we had designed a study using baked liver samples, a total of 98 collected from 2007 to 2022. And these were from Cornell and also from UC Davis, that collaborator I mentioned, Dr. April Choi. This was to try and accomplish a little bit of regional diversity because we see different liver disease in Ithaca, New York, and in New York State than in California, for example. So we looked at H&E sections, and they were evaluated for 15 different individual histologic features. And we performed in situ hybridization to visualize the nucleic acid. So we ended up with 53 cases from Cornell and 45 cases from UC Davis. Most of them were biopsies, but we also had postmortem samples. And we had a more or less even mix of thoroughbreds and quarter horses with some Arabians mixed in there. We had a pretty even distribution of sex, and we had ages ranging from 3 months to 33 years, average of 14 years, just to kind of give us that, that span. So just to show you, so we did a scoring system of 1 to 5, and so I have some representative images here. So kind of like that racehorse study, if you had just one positive cell, you'd get a score of 1. We have no idea what clinical significance that means, probably none. If you started having a couple of cells in those lobules, you'd get a score of 2. If you start getting 4 or 5, now you're pushing into a 3. And if we're starting to get, dozens of positive cells per lobule, you have a score of 4. And 5 is reserved for cases like this, which is a case of Tyler's disease. And so as you can see, we have got significant hybridization. These cells are overwhelmingly positive. The probe is just jumping, over itself to show you here. And so this was really encouraging to see, much better than our cases from Slovenia. And what's great is when you looked at that first image, you might have said, yeah, it looks like there's patchy redness. Well, the only areas where there is no redness or red stain is where there's no hepatocytes left. And so those are areas, central lobular necrosis is the classic histologic manifestation of Tyler's disease. And if you look at these dotted areas where that signal is less, those are the areas where those cells are gone. And so overall, we found that 48% of our cases were positive for viral nucleic acid, though the majority of those were a score of 1. So, most of them, I think, were probably clinically irrelevant. That being said, from the positive cases, we were able to pull out some information. So I was curious from a diagnosis perspective. So blinded to the results of the biopsies, looking at that pathologist's original report, what did they call this and was it positive or not? And we did see a statistically significant association between the diagnoses of cholangitis, lobular hepatitis, toxic hepatopathy, and hepatic necrosis. And I always have to qualify. You can ask me what, go ahead and ask.
Yeah, you're probably about to say it, but is this toxic hepatopathy, like, I couldn't figure out what it was, so I'm gonna call it?
Yes, and that's why I included that in there. And so we had to mention this to the reviewers of this paper as well. Pathologists get twingy. We're like, well, that's not a morphologic diagnosis. Oh, okay, excellent. So what I noticed as I was reading through these reports is that so many of them would say, oh, yeah, this is a toxic hepatopathy because we see features like megalocytosis, which we'll talk about in a second. So cell enlargement, we have some fibrosis, ductular reaction. There's a chronic injury here. I don't know what it is. We hadn't talked about, of course, viruses yet for the liver, so it must be a plant toxin. And so that's why I included it in this, so to get the word out there that, oops, maybe there actually could be something.
From the bottom of my toxicology, I think.
Okay.
I'm trying to figure out. And move like everything out. And like,
yes. I will say that it's always disappointing when I'm writing a report and I say, oh yeah, check for the viruses. That's probably what it's going to be. And then it's not. It's like, oh, okay, well, go look in the field for the toxic plant because I have no idea. So it still happens. So yeah, so as I mentioned, so megalocytosis, which is an enlargement of the cell, is a feature that we classically associate with usually pyrrolizidine alkaloid toxicity. So it's a plant toxin that can prevent division of the cell. And so you get these large abnormal looking cells. And so 50% of the cases in our study that had this feature were also positive for equine parvovirus. And so if you look here, this arrowhead is pointing out this quite large cell, which in the context of things may be hard to interpret, but if you look over here in the arrowhead, that's a more normal size hepatocyte. So you can fit 4 or 5 normal hepatocytes into that one large one. And we were able to see hybridization in those cells and in the neighboring cells as well. I don't mean to imply that that's actually an association, or like the one is causing the other, but just something for our diagnosticians to keep in mind, because again, just because you see this feature, something more may be going on. We also had a surprising number of cases with megalocytosis. So these are hepatocytes with multiple nuclei, which is something that we don't see too commonly in adult animals. You can see it with some neonates that are infected with viruses, and in humans with certain hepatotropic viruses, you can see multinucleation. But 75% of the cases in our study were positive for the virus, and the hybridization is a little bit tough to see here in these vacuolated cells, but there is positive hybridization in the nuclei and the cytoplasm. So in the Austrian study that I mentioned, the only 2 cases that were positive had metastatic neoplasia. We only had 1 case in our series that had a diagnosis of neoplasia. and that was of lymphoma. And so there was, if I remember right, T-cell lymphoma in our portal tracts. And so we were curious, okay, based on that study, do we see any relationships with the virus? Because parvoviruses like replicating cells. And if you've got a cancer, what better source of replicating cells than something that's dividing uncontrollably? Interestingly, in this case, none of the neoplastic cells were positive for the virus. And we were again able to confirm that the bile ducts were negative, and all of the virus was out in the lobules. So whether or not the virus is taking advantage of a concurrent hepatopathy is unclear, but that's kind of an open question for this disease. And lastly, something that we were really excited about was a demonstration of equine parvovirus hepatitis in foals. So we have from some of our studies evidence that foals can be viremic, but we don't have any case. We never had any cases of hepatitis. We detect the virus, but in theory, the foals would resolve. There'd be no signs of illness, and they never had any elevations in liver enzymes. So at the time, we thought perhaps, they're immune. If it's immune-driven, if the pathology is immune-driven, something to do with their immune reaction. But we were able to identify 2 foals aged 3 and 6 months who both had evidence of viral hepatitis and significant hybridization. And so this is the first case we were able to identify. So foals are also susceptible, not just our adult population. So a question we often get is, when do I test for equine parvovirus? So as I mentioned, we looked at 15 different histologic features, and this was my way of trying to figure out, okay, if I see this, this is what I should do. What features are associated with infection? And what we found was that there was a statistically significant association with individual hepatocyte cell death and central lobular necrosis. However, if you had evidence of fibrosis, portal edema, or neutrophilic infiltrates, you were much less likely to have parvovirus infection. And I'm a fan of algorithms, and so we designed this little handy-dandy algorithm for our diagnosticians, our pathologists, which we hope might be helpful. But in this diagram, you have a feature, and then you have an arrow pointing in that direction. And the more bolded the arrow is, the more likely it is that it's going to be positive, the more helpful that test will be in confirming it. So if you have central lobular necrosis, I definitely recommend testing for the virus, because actually what I've seen recently are cases of central lobular necrosis that come to me as a diagnosis of Tyler's disease, and they're negative for the virus. And so I'll mention in a second, I've started to notice distinguishing features between parvovirus-associated central lobular necrosis and cases that are negative. So if you don't have central lobular necrosis, you have individual hepatocyte necrosis instead. That is a feature that I still recommend testing for almost always in my diagnostic cases. One of the 2 viruses, either parvovirus or equine hepativirus, is present. And likewise, if you have lobular or portal inflammation without those 3 factors that I mentioned are negatively associated, then yes, I recommend testing. I felt reluctant to say, no, don't test. So I said, testing not prioritized as a way to, because I don't want to get sued by somebody saying, hey, you said don't do that. Anyway, so we hope that this will be helpful for some of our diagnosticians. This is the biased slide. So we do offer PCR of serum and liver at Cornell. I know UK VDL also offers it now, which is fantastic. And we do offer in situ hybridization diagnostically, so commercially. So if you ever have a case that you would like to look at to see the relationship of how positive it is, please let us know. We're happy to help you with that. As I mentioned, in those cases where you have a viremic course, but you want to know, is it causing disease? We can go back to those cases and look and see, okay, is it a score of 1, where 1 cell is positive and you just happen to catch that viremia? Probably not related. Or are you getting a score of 3 or 4, and you're starting to see many more infected hepatocytes, that's suggesting that this is an active infection? Yes?
When you were talking about with your PCR, you mentioned archive.
Yes.
So to what extent can you do the in situ? Can you do in situ? Are you doing it on paraffin embedded? You're able to do that?
That's a great question. Yeah, so I almost always do it on paraffin embedded tissue. And because this is a DNA virus, the nucleic acids are, very well preserved. We've done blocks 10 or 15 years old and still had fantastic signal. Equine hepatitis, not the same. Actually, as part of this, oh, perfect. Some of our other findings, so we did test all of these samples for equine hepatitis PCR of the formalin-fixed paraffin embedded tissue. What we found, though, is using known cases from some of those archive samples that had been positive but were negative on PCR, is that unfortunately it's only reliable up to about 2 years. And really, I would only do about a year. If a block is older than that, I would not trust it right now. So that's just something to keep in mind if you're doing your own retrospectives. As I mentioned, something I've noticed for our cases that are central lobular necrosis and parvovirus negative or positive is that cases that are positive for the virus do not have canalicular cholestasis. And this is a histologic feature that our pathologists will be familiar with. I don't know what that means. Perhaps those other cases are toxin related and there's some sort of subcellular hepatocyte injury that's causing that cholestasis. But this is a feature that I'm keeping an eye on to see if that's something that we can do before we do all the testing as a distinguishing feature. Unfortunately, Tyler's disease is very rare. And since I've started studying parvovirus, Cornell has not had a case. So isn't that always how it goes? Consistent with other studies, we have not seen a breed or sex predisposition to infection. So overall, as I mentioned, the prevalence is pretty high in the US. Subclinical infections are more common than those fatal acute hepatitis cases. Diagnosis is best done through serial PCR and serum biochemistry, plus or minus biopsy. And you can have a low viremic chronic carrier state after hepatitis. So this is why that serial comes in, because in our experimental infections, I didn't talk about this too much. We would see, score of 4, usually score of 3 or 4 in those cases in terms of in situ hybridization distribution. But we would do biopsies a week or 2 later, almost all gone. Liver recovers very quickly. Very little evidence of hepatitis, very little evidence of nucleic acid. Every once in a while, you'd see a positive cell, and almost always restricted to the nucleus. So I suspect that's some version of nuclear quiescence. So what I'm trying to get out into the world is that currently, whenever we talk about equine parvovirus hepatitis, the virus, we always talk about it in the context of Tyler's disease. What I'm hoping to do is that we can actually change the conversation a little bit and the narrative to equine parvovirus hepatitis, the condition, which ranges from subclinical disease with a higher incidence to more severe disease, lower incidence, ranging from subclinical hepatitis to Tyler's disease. And that if we're trying to figure out where that falls in the spectrum, we can use these kinds of tools to try and put that into context. So the main takeaways that I had for today was that viral testing should be considered for any horse with evidence of hepatitis, in my opinion. So, if you have elevations in liver values, I would say go ahead and test for both Hepatitis and parvovirus. Equine parvovirus hepatitis causes disease ranging from subclinical hepatitis to Tyler's disease. Again, this is kind of relatively new information, so don't discount it just because it's not Tyler's disease. We can see chronic infection with equine hepativirus, which leads to severe fibrosis. So if you have a case of equine liver disease with that cirrhosis-like lesion, I do recommend testing for hepativirus. If it's a biopsy, prognosis right now is not looking so great. Anecdotally, in cases that we've been following that have dual infections, so equine hepativirus and equine parvovirus, they do the worst. Usually we're looking at death or decline in 2 or 3 weeks. So having both at the same time is not great. And don't worry about those equine pegviruses for now, unless you study bone marrow. They are not something that you need to pay attention to. So I just wanted to touch base a little bit on my current project. So I'm not going to go into, as I mentioned, any of the molecular pathogenesis work that we're doing in any great detail. But most of this work is falling under a K award that I have, studying the mechanisms of parvovirus replication in viral hepatitis. And specifically, my questions are, does this virus require dividing hepatocytes to replicate? And can this virus take advantage of the DNA damage response pathways to replicate in non-dividing cells? And this is a relatively novel mechanism of replication for parvoviruses. And I'm hoping that equine parvovirus is doing the same thing. So I spent a lot of time and effort trying to develop a really exciting in vitro system to study this virus using primary hepatocytes from either cadavers or live horses. And because I'm a softie at heart, I wanted to have a renewable system where the horse did not have to die. So we developed a system using percutaneous biopsies of horse liver, and then trying and culturing them under different conditions. So we tried 3D spheroids, we tried matrigel domes, and 2D monolayers in various configurations. Sadly, none of them appeared to work for growing the virus, which was very sad for me. But luckily, the Schaefer lab here at University of Kentucky has been developing some really exciting techniques for culturing multiple organ systems, but specifically the liver. And Dr. Schaefer did a seminar at Cornell a couple of years ago, and is like immediately afterwards, we're like, we must talk. And it was super exciting. And so this week I have been working with Dr. Schaefer and Lynn to try and see if we can infect their model, which would really move the study of this virus forward. So thank you to the Schaefer Lab and University of Kentucky for hosting me this week. And with that, I'm all set. So if you have any questions, I'd be happy to answer them. Thank you so much for attending this afternoon.